Hello, students. This is Professor Karasi with your last and final chapter for general psychology. I believe this chapter talks about treaters. So let me go ahead and pull that up. Okay, yes, psychological treatments. So I want you to kind of think about holistically what treatments you would recommend. So if somebody came to you with a disorder, and let's say you were a diagnostician as well as a clinician, what would be your go-tos based on everything we've learned in this class so far? What types of theories would you incorporate? What types of methodologies or interventions or therapies would you think are especially important? Okay, so on slide 6, it talks about kind of the evolution of treatment, and long time ago, many people were institutionalized. Even in my parents' lifetime, I think that people were still institutionalized for psychological disorder because we did not have the resources, the knowledge, or the aware of them, how to treat them. One of the main hypotheses back then was that we just sequestered them. We kept them away from other people, and assumed that everyone with a psychological disorder was dangerous, which is problematic because, as we know today, that is certainly not the case. So it's a moral dilemma for sure. Psychotherapy is one of the top 5 recommendations for a wide variety of psychological disorders that we went over in chapter 14. So psychotherapy includes the treatment for psychological disorders in which a therapist works with clients to help them understand their problems. Therapists generally use psychotherapy to change their clients' patterns of thought or behavior. And what's good about therapy is not only can you hear yourself talk, but you can listen to the perspective of the therapist on the issue. If they're doing their job, they should be able to present many different vantage points of the scenario to you. So there's psychodynamic therapy, humanistic, behavior therapy, cognitive therapy, CBT, group therapy, family therapy, or dialectical behavioral therapy. We probably don't talk about that until you get to abnormal psychology, but that's also another very popular therapy. Psychodynamic therapy was based off of Freud's psychodynamic theory and other neo-Freudians. But basically, the treatment for psychological disorders in which a therapist works with clients to help them gain insight about how their unconscious processes may be causing inner conflict and impairing daily functioning. So, like we talked about before, Freud is a big proponent of the unconscious and the hidden, and his major hypothesis was that the unconscious gets in our way of getting what we want. So a lot of the techniques of psychodynamic or psychoanalytic therapy deals with free association, catharsis, dream analysis, and those types of things. Humanistic therapy is a treatment for psychological disorders in which a therapist works with clients to help them develop their full potential for personal growth through greater insight. Today's form of humanistic therapy is actually very, very helpful for people to achieve their greatest potential. It's kind of mirrored after Abraham Maslow's theory about self-actualization. Like I told you in earlier chapters, despite Rogerian therapy and all of Carl Rogers' great influences and things he brought to the table, his classical therapy was highly criticized because of the amount of repeating and rephrasing and summarizing and those types of things. Abraham Maslow brought about the idea of reaching your full potential, and that tends to be more realistic for people today. Behavioral therapy, treatment for psychological disorders in which a therapist works with a client to help them unlearn behaviors that negatively affect their functioning. I've seen people go to therapy, behavior therapy specifically to quit smoking. Doesn't always take, but those types of things, test anxiety, etc. There are some very classical behavioral conditioning techniques that can be done in therapy to help a person get started. One of the major critiques is that it may not be long lasting. And then cognitive therapy deals with restructuring the thought in an effort to change the behavior. And CBT is looking at both cognitions and thoughts. CBT assumes that the motive behind the behavior rests in thought. So if we change the thought, we will then in turn change the behavior. And generally speaking, this one is a very popular therapy because if we think about our own behaviors, there's thought that predisposes the behavior. So if there's an issue with the behavior and we change the thought, the behavior is likely to follow. Group therapy is interesting. Sometimes group therapy is very helpful for people, and other times it's not. When you've got a disorder, group therapies can be helpful in certain avenues, but not in others. So, for instance, with spectrum disorders, so developmental disorders like autism, group therapy might be very helpful in helping to fortify social skills and things like that. For substance use disorders, extremely helpful. The wealth of benefit that people report getting from AA meetings, NA, Al-Anon meetings, etc., is pretty impactful. But if you've got people, let's say, with personality disorders or even anxiety and depression or some of the other spectrum disorders, eating disorders, etc., having them in a group may or may not be helpful depending on the dynamic of the group and whether the group leader knows what they're doing. If you've got kind of a novice in the driver's seat, you can experience, and I have experienced this, kind of a runaway train phenomena in a group therapy setting where one or a certain number of people just kind of take over and it goes in a direction that no one was expecting, and people are walking out and getting angry and all sorts of very interesting things. So group therapy, people have to be very careful with, but it can be very, very helpful. Another thing they have on here is sexual abuse. That may or may not go well, depending on the level of trauma, depending on how fresh the trauma is, etc. I could imagine that a group therapy setting could potentially go awry if we're talking about something as personal as that. Family therapy has a systems approach, and this is also very good, especially if a child or an adolescent who is seeking therapy. It's good to bring the caretaker or the caregivers in once in a while, not always, but sometimes. The time of which you don't bring in caregivers or family is if they're part of the trauma of the client. If that's the case, it's not the job of the therapist to mend fences. They're not the peacemaker. They shouldn't be bringing people in that they know don't get along or have caused trauma to one another and try to fix that unless the client is asking them to do so. Cultural beliefs affecting therapy, undeniably. Different cultures have different views on psychological disorders and how they should be treated. So if you've got a person who is reluctant to come in, the therapist needs to be mindful of that. They have to know that a lot of cultures don't see therapy as a go-to and kind of work with that client slower than they would with others because of that hesitation. Biological therapy and psychotropic medication. I talk about this in the length in my abnormal class. In fact, students even do a paper on this one. lot of controversy about psychotropic medication. This is only Psych 1, so I'm not going to bog you down too much. But basically, what it comes down to is psychotropic medications are very good for alleviating certain symptoms, but they are not going to in any way touch the disorder. So, for instance, I have OCPD, obsessive compulsive personality disorder. There's no medication that will ever solve that for me, but I have spent over 20 years trying to find a medication that can help ameliorate some of the anxiety associated with OCPD. My Asperger's also kind of kicks it up a notch, and it's very, very hard to treat. So ultimately, clients have to ask themselves, does the benefit outweigh the cost? So in my youth, in my 20s, and late teens, I was on psychotropic medication that took away the use of my legs. So I was in a wheelchair for almost 2 years and I couldn't walk. And it was because of the psychotropic medication. And it took them 2 years to identify the cause of that. And I thought, wow, the benefit did not outweigh the cost in that situation. And I was very upset about that. Um, that's what clients have to do. They have to be savvy enough to ask themselves, do I feel well enough to deal with all the side effects or potential issues that this might be causing? For instance, with a antipsychotic med, which tends to be prescribed a lot more than what I think should be. Um, People can acquire tardive dyskinesia, which is uh, loss of voluntary muscle control. So imagine that. Imagine your face moving and you not doing that. Or your hands or your limbs. That's a scary situation. I've struggled with that because of medication in the past. So you have to kind of know what you're in for. Now, there are some medications that work well for some people and not for others. So if I found an anti-anxiety med that worked really well for me, it doesn't mean that it's going to work very well for someone with the same diagnosis, because all of our chemistry is very, very different. So basically, what I want you to glean from this is not to throw it out because psychotropic medications can do good, but also be aware of all of the other things that can come up as a result of taking them, and go in as an informed consumer and not put all of your trust in a psychiatrist or a doctor to tell you, oh, it's not the medication, these side effects would have been here. Not if you've not experienced them before the medication. So I just want you to have a level of awareness. For many disorders, the common practices, psychotropic medication and therapy. But finding the right psychotropic medication can take an awfully long time. So there's anti-anxiety drugs like Valium is a sedative, Xanax is an addictive anti-anxiety drug that only works in the immediate but not long term. And Ativan is another sedative that relays anxiety but only in the immediate. It basically puts you to sleep. Antidepressant drugs include Prozac, Paxil, Zoloft, Anafranil, Tafranil, and Alavil. Okay, so the last three are what we call tricyclics, and they have more negative side effects, usually a lot of weight gain, dizziness, sexual problems, etc. Same thing with the Prozac. Also with Prozac, Paxil, and Zoloft, not only have we observed those, but we've also observed depression and suicidal ideation in some clients. So it's really important that Prozac works for some, but not for others. Paxil works the same way, and Zoloft is either, from what people report, either they couldn't live without it or they never want to try it again type of drugs. Those three drugs usually go very dichotomously. Mood stabilizing drugs are usually heavier hitting drugs that people do not like to take because they make them feel lethargic, and that includes lithium, thorazine, and Haldol, which Thorazine and Haldol should not be used for a mood disorder unless nothing else has worked, because those are very heavy hitting historic drugs that have a lot of side effects and that make people feel really horrible. Oh, sorry, Thorazine and Haldol. That's why. That's in the antipsychotic drugs. That's what I was thinking. So mood stabilizers, there's lithium, there's Depakote, there's Cymbalta. There's some newer ones on the market that help mood. Latuda is another one, but insurances don't like to pay for Latuda, so people don't take it because they can't afford to take it, which is also another crime in my opinion. And then we get to the antipsychotic drugs, which are the heaviest hitting of the bunch. And that's where we get the Thorazine, the Haldol, which again, historically difficult drugs on the system. Clozaril, Risperdal, Zyprexa, and Seroquel. Those are the more modern day ones. And they're actually used pretty frequently with people, even with people who are not diagnosed with psychosis or a psychotic disorder. People with eating disorders are frequently given these drugs, which is, it shouldn't be. Um, what other cluster? Personality disorders. These are all very common. Risperdal, Zyprexa, Seroquel. All of these are very, very sedating. A Seroquel can put a person to sleep within minutes. And sometimes people have built up such a tolerance for Seroquel that they're able to function through the day with it. But again, the problem is Seroquel and Risperdal should not be used on an ongoing, continuous basis, especially because of that sedative effect, the massive weight gain that they cause, the changes to metabolism, the tardive dyskinesia, etc. And lastly, the two stimulants, which have gained a lot of momentum over the past 10 or so years that can cause a lot of harm in people if not monitored, are Ritalin and Adderall. Ritalin and Adderall have the same um, psychoactive component as the street drugs that are stimulants, that methamphetamine. So very, very addictive. People have a really hard time getting off of Adderall and Ritalin. Oftentimes, we're giving these two drugs to children, which there has been some success. I'm not going to say that there hasn't been. Some children have done very well with it, but my question is, as they grow, you can't have kid on Ritalin or Adderall for all of the years of life, that will absolutely destroy a system. So I want to know what other therapies are being coupled with that, and how do we essentially get off the child or the adult from that substance because it can be very addictive and damaging. Electroconvulsive therapy, I've never been a proponent of this. We have less invasive forms now, and I'm not even going to go over ECT because we shouldn't be doing this. I'm not confident that all areas of the United States are not practicing this, but this should not be a therapy. This has gained a lot of momentum, TMS, or transcranial magnetic stimulation, which is kind of an offshoot from the electrode therapy. But this is when a magnet is applied to the brain and electrical currents are applied to that brain region. I refuse to try it. I don't want anything to do with it, but some people have absolutely reported success with this, where they said that it has helped OCD or anxiety or depression. And then there are other people who say that their lives have never been the same in the negative because of this procedure. So again, all personal choices. Never feel pressured by any kind of doctor to do anything. Try a new med, try a new therapy, go undergo something like this. I mean, when we're thinking about this, your brain is vulnerable organ, and it is vulnerable to this procedure. So whether it comes out good, bad, or indifferent, you are assuming a certain degree of risk. Okay. Just skipping through some of this because I feel like I've talked about some of it. I'm going to go to the slide 27, where it talks about the providers of psychological treatment. Clinical psychologists, they either work in a company, like Kaiser or HealthNet or something like that, or they have their own practice, which takes a ton of money and a ton of um, clients. You have psychiatrists who prescribe the meds. That's what kind of separates them from the other professionals. They're a medical doctor. They have an MD, and they're the only ones that can prescribe medication. The rest, psychiatric nurses can also prescribe medication. The rest are counseling professionals who cannot prescribe medication. They don't have the license to do so. So technology and treatment, this is a big debate currently about the effectivity of doing therapy and engaging in these types of things online. I know that during COVID, people had to do it. Some people, however, for children, there's been a tick of clinicians who only want to online. And I don't know what that's about, but generally speaking, I don't know how that pans out. But a lot of parents I've spoken to aren't happy about it. They've had to pay a lot of money for people to come into their homes because their kid could not do it online, which is understandable. Goodness of fit on slide 30, super important. So just like with the psychiatrist, the therapist needs to be a good fit. If the psychiatrist isn't listening to you and they're taking 5 minutes to write a prescription and get you uh, out of their office, that's not a good sign. Unfortunately, that's a common practice of many psychiatrists, but they have to be willing to listen to you. Therapists do too. So if they're not a good fit, you are in the driver's seat. You can stop it. I'm not coming back, and you can look for another one. You can look online, you can read reviews, you can go in and see what kind of a fit. This might take a long time to do. But completely up to you. Exposure therapy is interesting. Exposure therapy is what we use for people with anxiety disorders and obsessive compulsive and phobia. So if a person has, for instance, a phobia concerning something, whether it be insects or bugs or whatever, the idea of exposure therapy is that we slowly show them what they're most afraid of to minimize that sensitivity toward the stimulus. And that's what systematic desensitization is, that we habituate them toward what they fear the most to kind of deplete the fear. Sometimes it works, sometimes it doesn't. Okay, so in terms of depression, I'm going to go to the depression slides. A lot of research says that CBT with psychotropic medication is very helpful for depression, and I agree with that. I think that people have reaped a lot of success from that. But then there are those people who are what we call treatment resistant, and no matter what antidepressant you try for them, it doesn't work. So oftentimes they then experience greater depression and greater anxiety about none of those psychotropics working. Mood stabilizers we talked about, and your PowerPoint gives you some examples of people who struggled with mood disorders, which is interesting. Michelangelo, Vincent van Gogh not only had mood disorder, but he had some other things going on. Georgia O'Keeffe and Ernest Hemingway, as well as a lot of um, writers and artists. Edgar Allan Poe is another one that comes to mind. Prognosis is a prediction of the likely course of a psychological disorder. So prognosis looks at how likely is a person to recover from this. So for instance, I told you I have OCPD, I have autism. That those things will never go away. The prognosis is not good in that area to say that, oh, if I do this, that, and the other, then I'm not going to have it anymore. I'll always have it. It's just a matter of managing it to where it's digestible. For other people, for instance, if a person has a particular anxiety disorder that has a higher prognosis, like PTSD has a phenomenal prognosis. while it's steeped in trauma, if the person undergoes therapy and all of those things, the idea that that trauma response will deplete is exceptionally high. Their prognosis is very good. Schizophrenia, prognosis not as good. And some of the other types of psychological disorders. Again, tardive dyskinesia is on here. I tell my students this all of the time in abnormal. Now we're making medications to treat a side effect associated with medication. So now there's a brand new medication out to treat tardive dyskinesia, which is irreversible. And tardive dyskinesia happens as a result of some psychotropic medications. So you see how now we have to treat a symptom because we took a medication that caused something that we didn't have before. And that's an example of tardive dyskinesia, the man with his tongue out, where that's happening and he's not doing that. It's involuntarily happening to him, which is really sad. Antipsychotics, I talked to you about the host of negative side effects associated with those. And what also happens with the antipsychotic class is that people don't want to take the medications because they're causing them such distress in terms of side effects. So personality disorders, this is an interesting sub part of the chapter. There's a lot of contending research, and in my abnormal class, my students have to look at this controversy as to whether certain personality disorders can be treated. There's one school of thought that says yes, absolutely, with therapy, medication, monitoring. Another class says no, there's no way that they can be treated. The best thing we can do is either institutionalize them or sometimes incarcerate them for antisocial personality disorder if they've committed a crime, which is highly likely, etc. One of the common therapies that tend to help some personality disorders more than others, especially in treating borderline personality, is DBT. It combines behavioral therapy with cognitive therapy, with psychodynamic therapy, and a mindfulness approach. So it's a more complicated therapy that looks at a variety of factors. Then there's APD, people with antisocial personality disorder. For those of you who don't know what that is, another word that we use for it is sociopathy. When a person lacks the ability to feel empathy, when they go out and hurt and defy the rights of others, and they have no remorse for that. And that's what my students write about in abnormal is, do you, after you look at the research, do you believe that APD is treatable? Do you believe that people with APD can be reintegrated into the society without significant risk on societal members? So that has been a controversy and will continue to be one. And one of the things that I always ask is, what are they doing in the prison system to help? So yes, these individuals are generally incarcerated, but they should be receiving treatment on how they're not going to change the disorder, but on coping mechanisms, on resistance toward a dangerous impulse, those types of things. And I don't know that they're necessarily getting all of that in the system either. So I talked about autism, behavioral therapy for autism, ADHD, again, behavioral therapy, cognitive behavioral therapy, and oftentimes parents will go to the Ritalin and the Adderall. And that will do it for that chapter. And well, I won't see you next time because that was our final chapter, but it's been a pleasure doing these for you guys. And I will talk to you soon. Bye-bye.